I'm going to go ahead and record this in case anyone wants to take a look at this. All right. And let's see. See, how do I get the chat back? There we go. Let's put that right there. All right. So we're going to go ahead and get started. So again, it's just intermixed, but we're going to start with musculoskeletal. All right. Here we go. So question number 1, which of the following is characteristic of a patient with decreased lumbar lordosis and then they have posterior pelvic tilt? Yeah, so that one, hopefully that was pretty straightforward. He's done a question very similar to this, so I'm just going to take a wild guess that that's going to be on there, but we can definitely go over that. So we've got somebody, I probably should have reversed the order so it's a little bit more understandable. They've got posterior pelvic tilt, which implies that they probably have decreased lumbar lordosis, because when you've got anterior pelvic tilt, which is what he usually asked it in that form, they would have increased lumbar lordosis. So here we go. So this, if you guys hadn't seen it, probably as some people have, I had posted a bunch of these slides in, some of these are taken from that review that I put up. But so remember, when we're looking at the lumbosacral angle, the way that's helpful for me to think about it is if you actually look at L5 and S1, so that intervertebral disc, because it's not just completely vertical, right? It's actually tilted in neutral state right here. And if you draw an imaginary line right through that intervertebral disc, that's the lumbosacral angle. And so relative to horizontal, it's normally about 30 degrees. And so you naturally have some pelvic tilt there. But as we know, we can have some anterior tilt, or we can have some posterior tilt. And just remember that when you're talking about anterior and posterior tilt of the sacrum, we're talking about the superior part of the sacrum. So if the superior part, the part that's in contact with L5, if it rotates anteriorly, that's your anterior pelvic tilt. And then if it rotates a little bit more posteriorly, that would be posterior pelvic tilt. So if you've got this intervertebral disc between L5 and S1, right? So it's naturally a little bit tilted like this with the lower part more anterior. So if you rotate the sacrum anteriorly, you get a slightly higher angle, versus if you rotate it posteriorly, you get a smaller angle. But in any case, so you guys hopefully remember that you got these different muscles here in like 4 quadrants around this line. And so in the case of posterior pelvic tilt, which is what we had here, in this case, relative to neutral, as the question said, you're actually going to have tight glute max and then tight abdominals. So these ones right there was anterior pelvic tilt. Let's see, so Morgan, was anterior pelvic tilt counter nutation and posterior pelvic tilt nutation of the sacrum. Does anyone know the answer to that one off the top of their head? Because that one I do not honestly remember.
I think it ends here.
Is anyone having trouble understanding? Yeah, do you actually want to type that? So anterior is nutation. Yeah.
An anterior sacral tilt, yeah, is regular nutation.
Yeah, I didn't know if it was something weird, like if we were talking about something relative to the pelvis or, yeah, so when you have that
Because the
anterior
sacrum's
tilt,
gonna forward. I'm not 100%, but I'm
okay,
like
so it's
90%.
not anything weird. Okay, okay. So yeah, so anterior tilt would be the nutation and then posterior would be counter nutation. And when you look at this, you've got here, in this case on the right, so the rectus abdominis and the gluteus maximus, remember, kind of like across from each other, crisscross, those are going to be the tight muscles. And then in the case of erector spinae, so the back muscles, back extensors, and then the hip flexors. Yeah, that's right, Jeremiah. Yeah, thank you. So Jeremiah said that nutation is specific to the sacrum, not the entire pelvis. So it's the sacrum moving relative to the pelvis. I don't remember if he went over that in this, but yeah, that's what it was I was trying to think of. Yeah, so when you have anterior sacral tilt, it's posterior pelvic tilt. So they're actually moving counter to one another. I think for this, though, the main thing just to remember is anterior pelvic tilt versus posterior pelvic tilt. So in this case, you've got tight rectus abdominis, tight gluteus maximus. And so if you think about where these muscles are, where they're pulling, if you think about the gluteus maximus, it's going to pull downward. So that's going to rotate this line downward relative to neutral. And rectus abdominis is going to pull upward. And so if these two muscles are tight, that's what's going to produce that posterior pelvic tilt. Erector spinae and hip flexors would be, in this case, the weak ones. So these two, the red and the blue, were flipped in this case. Yeah, like they're locking together. Yeah, exactly. And then on this one, in terms of the load on the facet joints, it would actually be increased. I think I may have had this one.
Can I stretch on your mat?
I think someone has their mic on still. Oh, okay, cool. And then with this one, lumbosacral angle would be decreased. So, I mean, we don't know what value it is, but the normal value is going to be about 30 degrees. And so if you have posterior pelvic tilt, it's going to be maybe like 20 degrees or something like that. And then with anterior pelvic tilt, which is normally what he'd ask, and I have a feeling he would probably ask more about the anterior case where everything's flipped. But anterior, you would have an angle above 30 degrees, so maybe like 40 or something like that. But remember, those angles for the lumbosacral angle are different than nutation and counter nutation. So the nutation is just movement of the sacrum relative to the pelvis. These movements are pretty much movement of everything as a whole. So these movements are a lot larger. The sacrum is kind of locked in the sacroiliac joint between the two halves of the pelvis. So that relative movement of the sacrum to the pelvis is really, really small. And I think somebody actually said that up here. Yeah, Chris said that. There's barely any movement. I think in anatomy it was like 2 degrees or something. But when you're looking at these movements, or not really movements, but deviations, they're much larger because you're looking at the entire lumbar spine relative to that sacrum. So the deviations here can be a lot larger. So, okay, so yeah, so on this one, the answer is lumbosacral angle is decreased below 30 degrees for posterior pelvic tilt. Okay, let's go to the next one. There we go. Let me move this over here, actually. Which of the following is not a typical characteristic of a patient with ankylosing spondylitis? Right. So this is one of those things where he's probably going to have at least a few questions on these where you've got these non-mechanical kind of red flag type of conditions, right? So I think the last one he talked about, ankylosing spondylitis. Yeah, so Nicholas is right there. So it's the second half of the night. So if you look at those conditions, this is not ideal for that. Move this over here. Here we go. So ankylosing spondylitis. So The itis, this is the way I remember it, itis in the name tells you it's inflammatory. So you're looking at people with a history of inflammatory conditions. So in this, IBS, irritable bowel syndrome, that's an example of an inflammatory condition. The other one he mentioned was Crohn's disease. So if they have a history of that, that would be something that would be more characteristic. So that's not the answer because it's not typical. It wasn't in the PowerPoint slide, but he did mention it verbally. So usually people with ankylosing spondylitis are younger patients. And I think he said basically in the 20s and 30s. So I just said late 20s. So this would be typical. And not that women can't get this, but it did say that men tend to get this more than women do. And they're a lot younger than some of the other conditions that are on there. And with this one's also is characteristic of this, because remember, you've got 2 hours of morning stiffness, 2 to 3 hours, and it doesn't improve with rest. They wake up with morning stiffness in it, and if you look at it, it has to be at least like 30 minutes. So morning stiffness greater than 30 minutes, but it improves usually with exercise and not rest. Also notice those other two things. So I didn't put this one, but you've got alternating buttock pain. And then this one is kind of the one that I flipped. So the night pain that is during the second half of the night. So this one would imply that the worst pain is actually in the first half of the night. Because if it's improving as the night goes on, then that would mean that the first night is worse and the second night's actually better. But the night pain is, as Nick said, worst in the second half of the night. So that is, so that makes this the answer, not characteristic of that. And I would definitely, one of the things I would go back and take a look at is all these characteristics and things that allow you to rule it in. On the last, I think it was TI2, the TI2 exam, I got lucky on a few, but I kind of just glossed over those lists of like contraindications, precautions, all that stuff. And this time around, when we have the exam in there, I'm going to make sure I really memorize all that stuff. But I think they expect us to have all that stuff down pat and memorized. So if you haven't done so, make sure you go back and do that, because I have a feeling there's going to be quite a bit on there, and they can get probably nitpicky with some of the choices. So ankylosing spondylitis. Next one, number 3. Which of the following is not characteristic of the proliferative phase of healing? Yeah, so anyone in the chat, why is this one not characteristic of the proliferative phase, which remember is the second phase? Yeah, so yeah, some people, yeah, type 3 collagen. So that's just something minor like that. But again, he did say to definitely, this is of course TI1, but he did to definitely have these down pat for all the phases. So he did say when you're in the proliferative phase, you can start progressing from passive range of motion activity to active assistive. In terms of active range of motion, I think he said to mostly associate that with the restorative or maturation phase. I think there's some overlap and stuff, like toward the end of proliferative, if they can tolerate it, maybe you can use active. But he said in the sync session, I think somebody, yeah, that's true. Yeah, so we don't want to, yeah, Nick is saying that we don't want to give absolutes basically, and that's true. There's one slide where it talks about the different things associated with each phase. It's like a table of like 5 things, and at the bottom, it has precautions and contraindications. It does say that you can go from passive to active assistive, and then toward the end, active assistive to active in proliferative. But in the sync session, he did say at some point that active assistive was indicated in that section. So, but again, I think the key here is make sure, remember, Don't go with those absolute answers. It's as the patient tolerates. But also making sure not to go too far, because remember, especially in those early parts of the proliferative phase, if you induce that inflammation again, because you're going too vigorously, you can cause it to regress back to the inflammatory phase, basically. And then you have angiogenesis, epithelialization. Remember that angiogenesis is just the synthesis of blood vessels. So when you have damage to that area, you need to get supplies into the damaged area so that you can rebuild it. It's kind of like if a house burns down, right? If a house burns down, if you want to build a new house, you have to clear that out first. So that's inflammatory because you're getting all of the white blood cells there to phagocytize everything. But then you have to first build a framework for the house. So you've got the drywall, and I mean I'm no contractor or anything, but you build the frame of the house first. That's kind of like the proliferative phase, and then after that you kind of put all the solidify it, and then it looks like a house, which would be maturation. So you got to get the blood vessels in there so that you can get the supplies there to rebuild it. And one of the other things that happens in there is you've got the fibroblasts. So they're proliferating and they're depositing all sorts of proteins and stuff. But remember, they're synthesizing at this point type 3 collagen, which is weaker than 1. And it's only until you get to maturation that you start to get the destruction of type 3, and then you get the building of type 1 to replace that. And then in maturation, it becomes mostly type 1. And then with this is a little bit overlap from TI2, but again, he said to still know this. So remember, when you're looking at the times, it's variable, definitely, but at least in TI2, remember inflammatory was days like 0 through 6, so the onset up to day 6. And then proliferative is 3 to 20. And then I think maturation was 9 and on. So remember, there's a lot of overlap between those. Okay. Anyone have any other comments on this before we go on? I'm guessing one of the big things to pay attention to on these phases is not just the events that are going on, like physiologically, which he did say to know. He probably is going to have that, but also to make sure generally what kind of exercises would be tolerated in each. So like passive range of motion is mainly going to be for your inflammatory phase, and then you theoretically want to progress it once you get to proliferative. So in terms of Morgan's right. So neovascularization is the same thing as angiogenesis. It's just the generation of new blood vessels. So yeah. All right, next question, number 5, I think. Which of the following is not a factor that would rule up cauda equina syndrome? Let's see. So on this, let me make sure I didn't make a mistake on it. Okay, so cauda equina syndrome. So let's go to that. So that stuff, the stuff to rule up or rule it out. So again, things on that. Remember that it's neurological emergency, and you need to get it treated within 72 hours. I think Dr. P today was saying that actually one of the ways you do that is a lumbar laminectomy. I doubt that'll be on the test, but you got to basically free those peripheral nerves so that they're not being compressed in some way. Otherwise, you get permanent damage. So 3 things. You've got urinary retention, so unable to void urine, saddle anesthesia, and then sensory deficits anywhere between L4 and S1. David, that's I don't remember where I don't even know which instructor said that, but there was one thing that said initiating urination was the problem. And I think they were just using the term initiating kind of loosely there. But then, then in the sync session, I think the one on Tuesday, if I remember right, he was talking about how you can kind of initiate it, but in order to get the full voiding of the bladder, you have to contract the detrusor muscle, which is some smooth, I don't know if it's skeletal or smooth muscle, but it surrounds the bladder. It's in the wall. And when it contracts, it squeezes the bladder and it shoots the urine out, basically, kind of like a tube of toothpaste. And so on this one, I purposely put that in there just because, just in case he were to put something on like that on the test. So it's not specifically difficulty initiating, it's the failure to contract the detrusor muscle to urinate. And I think part of the reason for that is if you think about where the bladder is and what might innervate it, the motor innervation, you're talking about in the pelvic cavity, right? Because that's where the bladder is. And so remember, in that cavity, you have some of the sacral nerves. So you got sacral nerves, you've got basically things that come from the cauda equina. And so if they're being compressed, then that's going to affect the innervation to that muscle. And then you're going to have issues voiding the bladder. And I think that's the rationale why that is. Saddle anesthesia, that's one of those. And then in terms of the sensory deficits, for this, I was just thinking of the dermatome. And so when you're looking at those, so let's see, so L2 is mid-thigh, L3 is medial knee, L4 would be medial malleolus. And so third dorsal metacarpo, that is my fault. I wrote that really fast. So if anyone put this one, that actually would be false. I meant metatarso-phalangeal region. That is my fault. But yeah, if this was third dorsal metatarso-phalangeal region, then you'd be looking at the L5 dermatome, and then posterolateral calcaneus is S1. And so L5 and S1 are certainly within this range right here for the sensory deficits. So I guess in this case, this one actually might have actually been the best answer, but I meant to say metatarso-phalangeal region. But if it actually did say that, then the answer is definitely difficult initiating. I believe that's right, David. It sounds about right, because the spinal cord ends around somewhere between L1 and L2, so I would imagine it includes L2, but I don't know that for a fact. That if anyone wants to look that up and tell us, please feel free to do that. But yeah, it's true. Thanks, Pius. Thank you. So it starts at L2. So that's one of those red flag conditions. Just a question, just from the lectures, the sync ones. Which one is more immediate in terms of needing to get medical attention? Is it cauda equina or is it ankylosing spondylitis? Yeah, so this one was a lot more dangerous. And so the 72 hours, which is 3 days, you basically get it treated within 3 days. Otherwise, you can have the lasting consequences. So sensory motor deficits, all that stuff. Okay. And by the way, if just kind of a aside, so if this person had cauda equina syndrome, from that triage of like deciding what to do with the patient, which one of those three would the patient be classified as? Yeah, so refer out and yeah, so Brent, yeah, medical management. So remember with that triage, you've got, there's the medical management, rehabilitation, and then also basically self-management. And so because you'd have to refer out to this immediately, it'd be medical management. So, okay, next one, number, I don't know which one, 5. Identify the treatment strategy. So we've got lateral sural pain and numbness, high irritability, a positive neuro exam, and a positive cross straight leg raise. Yeah, so this one's traction. So let me pull this up. Where is it? This one? No, it's not that one. I think it's actually, I think we can do it this one. Yeah, so yeah, this will work. So he's had quite a few of these in the, throughout the sync session. So I have a feeling there's probably going to be at least like probably, 4 or 5 of them on the exam. So remember that once you get, so with that triage, you've got the medical, and I think I may actually, no, I don't have it here, but you've got the medical management, which is refer out. We just mentioned that. Here's the rehabilitation, which is where you're going to, the physical therapist would deal with it. And then you have self-management, which I don't envision him having any questions really much on that. But once you decide that they're appropriate for PT, so the rehabilitation, then you have to choose whether it's symptom modulation, movement control, or the functional optimization. And so basically that's manipulation, stabilization, and then specific exercise respectively. So I put this together just with all the major things that are help rule it up. And in case anyone was wondering, because I got a few questions on this, the red ones here are the rule out. So these would actually discourage the decision to put it in that particular category. So, so for example, the person has in the question, so we've got lateral sural pain. So sural pain, sural is the calf region. So there we've got pain past the knee. And so if we got pain past the knee, that pretty much rules out using manipulation, so putting them in the symptom modulation category. Remember that, at least what the sense I got was, I mean, there can be things that rule this down, but if you have symptoms below the knee, pretty much manipulation is contraindicated. And so if you have symptoms below the knee, then you possibly need to be thinking either radiculopathy or radicular pain. And I don't know if people had gotten off yet. I don't remember when he did. It was toward the end of the sync today. But Dr. Young had a really good explanation of radiculopathy versus radicular pain. So if you didn't get a chance to take a look at that, go back and watch the sync. But the gist of it is basically that, and he kind of already went over this, but if you're talking about radiculopathy, you have to have one of those 3 conditions satisfied. So you have to have either the dermatomal dysfunction, so that sensory loss in a dermatomal fashion. You have to have the strength loss in a myotomal fashion, or you have to have the reflex loss. So basically they have to have a positive neuro exam. If they don't have a positive neuro exam, if it's negative, then it might possibly be just an irritated nerve root. And then he said irritated nerve root was just radicular pain. But radiculopathy has to have that positive neuro exam. And then you can have radiculopathy basically with or without pain, is basically what he said. But if you go back and look at that, if you left or whatever, I don't remember if it was actually after he ended class, but it was a really good explanation. So yeah, I think with before we go finish this, just real quick, David, yeah. So with specific exercise, including directional preference, I think that they're strongly linked. I mean, I think directional preference really has to do with just if extension is what actually gets rid of their symptoms, then they would actually engage in extension type of exercises. But I think directional preference more was part of the McKenzie classification, which is, the sense I got was it was similar to specific exercise. And then Morgan said, I think specific exercises is different than, I think they are different mainly because the specific exercise is really under this classification. And then directional preferences is for the McKenzie classification. I think that's the major differences, but they're really similar. And okay, back to this question. So we've got Right. Yeah, thanks, Pius. So this person has a positive neuro exam. So if they've got basically pain below the knee, and they've got a positive neuro exam, I think the sense there is that it would probably be a radiculopathy, not just the irritated nerve root, which would be radicular pain. If this had been a negative neuro exam, it probably would have been just radicular pain, so an irritated nerve root. So I was talking to him about this after class and through emails. And so I think what he's leaning towards is that basically they have pain below the knee. So this is at the calf. And then they have a positive neuro exam. You can start to rule in the radiculopathy. But if it's negative, like I said, then you can start ruling out, or ruling down, I should say, the radiculopathy. So they also have a positive cross straight leg raise. And so if they have that, that's another sign that they may have a radiculopathy or just something wrong with the nerve root, whether it's a full radiculopathy or radicular pain. And so if they have symptoms below the knee, you pretty much have manipulation being contraindicated. So you either have a radiculopathy or radicular pain. And there were a few things that they said that could indicate that you have a problem like that. One of them was the cross straight leg raise. I think it was also with the regular straight leg raise, if you have pain below 40 degrees of hip flexion. So when they start raising your leg up in hip flexion, if you have pain less than 40 degrees, that's a positive sign. Also, that positive slump can indicate that. And there were a couple other things, but I don't think they were like really that important. He talked about a femoral nerve exam or test. And then also if you cough or sneeze and you have a lot of pain there in that region, that may indicate that you have a disc problem, and the disc might be, compressing the nerve. And so then if those things lead you toward that kind of pathology, then you have pretty much either traction or you have slump stretching. And this is something I talked to him after class about. So there was a question on in one of his sync sessions where, and I actually have it in the in my main review PowerPoint that's on Facebook. And there was a conversation some of us were having on Facebook about it. So if any of you want to go look at that, it's pretty obvious which one we were talking about. But he had two answers that could both technically work, and it was traction and slump stretching. And in the question, you can technically have both as the answer. And he didn't mean to put that question in there because we hadn't really gone over slump stretching that much in the class. But what I asked him about is, how would you choose traction versus slump stretching? And this is what he said. It depends on the irritability of the patient. So if their condition is highly irritable, you would use traction. If it's a low irritability type of pain, you would use maybe more slump stretching. And remember, with slump stretching, he showed one thing on it, I think, and it's basically where you flex your entire trunk forward, you flex your neck forward, and then you can have one leg up, and you can even dorsiflex the ankle. And he had us do that in class, and it's kind of uncomfortable. And remember that when you go into full flexion, like pretty much throughout your whole body, you're tensing the nervous system, and that can create some pain. And so because it's sort of an intense thing where you're stretching the nervous system, if the patient was highly irritable, you would not do the slump stretching. If they were highly irritable, you would use the traction, because the traction is a little bit less, I guess you could say, less vigorous. So if they're having a lot of pain and a lot of symptoms, you would choose traction because it's kind of easier on the patient. But if they can tolerate it and they have a low irritability, then you can get by using slump stretching. So does that make sense to everybody? Any comments on that? If anyone has any questions, let me know. We'll go on to the next one. But remember, basically, if you've got that pain below the knee, if you've got neuro exam that's positive, and then a cross straight leg raise that's positive, those are going to be things that lead you toward perhaps a radiculopathy. So in that case, you might use traction. All right, next question. Identify the best treatment strategy. So low back pain centralizes with spinal extension, peripheralizes with flexion, and this should say no pain below the knee. Yeah, so this one's specific exercise. So if you go and look at some of the criteria for putting them in functional optimization, which implies specific exercise. So one, I didn't put this here, but they have a preference for sitting or walking. That was one of them. And then the other two were, there was centralization with a particular motion testing. So for example, if they, like extension, I think, was this one? Yeah, so their back pain centralizes with spinal extension. So remember, centralization is something that we want. It's a good thing. So if they have a centralizing motion, it doesn't have to be extension, it just was here. That can help you rule up using this treatment approach. And then also this one, it was written like this in the PowerPoints, but from what I understand, this means peripheralization with movement in direction opposite to centralization. Basically, if you have, I think it's if you have a centralizing movement, so in this case, extension was centralizing for the patient. If the opposite movement, so flexion, was peripheralizing, then that will also rule up using this particular approach. But the other thing also here is that if they have no distal symptoms, that will actually rule it down if they have no distal symptoms. So remember that you're looking at centralization. So so that would imply that they might actually have some pain in the thigh or something like that. And so you'd want to centralize it and get it back up contained in the lower back. Let's see. So on this one, there's no pain below the knee, but there still could be pain in the thigh. And so remember that when you're talking about that peripheralization versus centralization, it doesn't necessarily have to go down it doesn't have to go down all the way to the calf or something like that. You can have that peripheral pain in the thigh, in the hamstring or quad area. But as long as when you do that, in this case, extension, as long as it brings that pain back up to concentrate it in the low back, that would be considered centralization. But if it goes the opposite direction, you got peripheralization, that's bad. But if it's peripheralizing with the antagonistic movement, then I believe it's one of those things that rules it up. Let's see, so Lauren, the Fritz classification presented in one of the reading supports, manipulation for centralization, Fritz classification. Yeah, and which one, I don't, the name, which one is the Fritz classification? Is that
one of the ones that's presented, but it's not the one that we're responsible for knowing. So I agree that the specific exercise is the correct answer here for like our stuff, but there is another classification that was presented to us that offers that other option as well. So if
okay.
Answer that.
Yeah, and that actually reminds me of one other point. If you guys remember to, one of the things that apparently he likes to test on, and this was told to me through Sydney, the class president above us, he said that if you go back and look at all the papers that he posted and just kind of know the general idea of what it said. So like I would probably go and read the abstract, and then if there's a conclusion section, I'd probably go and read that. I'm not going to kill myself going reading every single word in every single paper, but If there was a main idea from those papers, make sure you go back and look at those. I might do this tonight, like after this is over, after I eat dinner. I may like try to make just like a table again, like go through it and try to get all that stuff. And if I do that, I will post that on Facebook so everyone can have that with all the main ideas of all the papers. But apparently he likes to test on that. So definitely go back and look at those things. Thanks for reminding me of that, Lauren. So yeah, here we've got specific exercise. All right, next question. We're identify the best treatment strategy. So we got acute, low back pain, pain extends to anterior mid-thigh, hypomobile with CPAs. Yeah, so this one is manipulation. I think the main thing for me, like when I look at this stuff, that gives it away is the hypomobile with CPA. So remember, CPA was one technique. I think it's central posterior to anterior forces that you're putting on the lumbar spine. So the patient's lying in prone, they're on their belly, and you're basically with whatever hand position, you're doing central posterior to anterior movements. There's also UPAs. Yeah, and that's, yeah, so Pius, that's good. Thank you. Both CPAs and then UPAs, which aren't mentioned here, are both two different ways to do the spring test. And so if you look at, here we go. So with manipulation, the things that would favor this, so recent symptom onset, so if it's acute. So acute's one thing. We've got hypomobility with spring testing. So they have lowered range of motion there in the lumbar spine. No symptoms below the knee, because remember, if you have symptoms below the knee, pretty much manipulation is ruled out for the most part. And then he hasn't really used this in any of his questions, but that fear avoidance behavior questionnaire, FABQ, if they had a score below 19, that would be one of the things that would rule up manipulation. Does anyone have an answer for that? Because with the UPAs, I thought the UPAs might have been more on the other side of like basically lateral to the spinous process. I'm not sure about the CPAs. I didn't think it. I looked at the information on Physio U, and I didn't think it said that specifically. Yeah, it probably is more of a lab thing. I would guess that we would just need to be able to recognize it from a picture. I don't know if he would. I know there's differences in hand position, so I would go back and look at those things on Physio U to make sure you can differentiate them. But other than that, I think what he probably might do is just put a picture of the spring test and just basically ask what it is, not necessarily details like that. I'm probably just, yeah, what's up?
I was looking at some of that today and was reading some of the differences.
Mm-hmm. Yeah, go for
so
it.
it's basically, of course, it's still directed in the same direction, but like you just said, the two hand placements. But from what I was reading in some other texts that we have too, it's directed like into the spinous processes.
The central
like
one?
Specifically. Yeah.
Okay. And then the UPAs, the unilateral, those are on either side. Is that right?
That I think so. I know. Yeah, but the central one is like direct to the spinous process. That's what I just wanted to mention.
Okay. Thank you so much for that. Thank you. So yeah, that's a good point. So central one, CPAs, which is kind of like what we got here, those are directly on the spinous process. And then the UPAs are going to be on the tissue on either side of that. But those are both two ways to do the spring testing or spring test. So this one is manipulation, but probably the big thing here would be the fact that there's nothing here that indicates that it extends below the knee. It just extends to the mid-thigh. With these questions, because I think he's going to have a lot of these, or maybe not a lot, but I mean, he's definitely gonna have some of these. The way that I go about doing these questions is that I would make sure to go and look at these things, particularly the things that rule it in. So you've got really 4 on manipulation, 2 big ones on stabilization, 4, I guess, total, and then 3 on specific exercise. And then I just kind of go through the question and look for keywords that are from those, or at least key concepts. So like on this one, hypomobile is something that really jumps out. Hypomobile with CPAs, hypomobile with spring testing. So when you're going through these questions, look for the keywords or key concepts that come directly from those lists of factors that rule it in. I feel like on these, if I tried to read them as the question as a whole and tried to just like look at it more globally, it would be much harder. So when I'm going through these, just look at the keywords here. And then always pay attention to whether or not there's pain below the knee or not. And then on this one, he had one similar to this, that acute. The acute onset is, again, recent symptom onset. So that's another one of those things, even though it's not the same word, the same concept. And it might actually be helpful when you're doing these questions to just take a longer time on these questions and just do it, a few words at a time. And just as you go word by word, ask yourself, does it fit one of those factors on here or in the PowerPoints? So hopefully that helps. I think there's one more of those. 35-year-old patient, hypermobile SLR, and reverse lumbopelvic rhythm. Yeah, stabilization. So with stabilization, with these 4 things, just a word of warning. There was in Dr. Adams' lecture on this. So the first 2 right here were the only ones that were validated. He talked about those studies. Then they did a second one, and then it validated only the first 2. So when you're looking at the stabilization movement control category, the first one, you've got a positive prone instability test. And then the second one is any aberrant motions. There was a table he had somewhere, and I got it right here, just directly from there, that gives you some of the aberrant motions. Like this one, I thought this meme kind of just looks like that, is the Gower sign, where basically once if you bend over to pick something up off the floor, to get back up, you kind of have to inch your hands kind of up your legs. That would be an aberrant movement. And then also, like the one here, they have altered lumbopelvic rhythm, so that might be a good idea to review the normal lumbopelvic rhythm. And if you hadn't downloaded or looked at the picture that I had posted in the comments there, initially when I posted this, I had this reversed, so I apologize for that. But just in general, when you're looking at the normal lumbopelvic rhythm, so we're talking about movements of the lumbar spine versus movements of the hip. And with the hip, we're really saying anterior pelvic tilt or posterior pelvic tilt. So in the down phase, that's like when you're bending down to pick something up. So the first third of that movement is not all, but it's mostly lumbar. So if you're bending down, that's definitely lumbar flexion, but I just put lumbar there. And then as you're bending down, the last third of the movement is mostly at the hip. And that would have to be anterior pelvic tilt. And then when you do the up phase, so you're basically extending back up to erect standing, everything's reversed. So instead of so it went lumbar hip, now it's hip lumbar, but the movements are the antagonists. So instead of being anterior pelvic tilt, now you got posterior pelvic tilt. Yeah, I tried this first, and I honestly thought that, I think that's why I actually messed it up the first time, because when I did it first, I don't know why I thought my hip movement was going first. Maybe I'm just messed up or something. But when you're going back up, you've got posterior pelvic tilt, that is in the first third of the movement going back up, and then you have the lumbar part. But of course, when you're going up, you're having to do lumbar extension. So these are just mirrors of each other. So lumbar hip, but then it's hip lumbar. And then just kind of think about the movement. So you don't have to really memorize it, but just think about what you're doing. If you're bending down to pick something up, the lumbar would have to be lumbar flexion, versus when you're coming back up, it would have to be lumbar extension to get you back up to erect standing. But in any case, those are those aberrant signs right there. The first two are really more of the, I guess, the kind of have to learn those. The other ones are maybe a little more, I guess, I don't want to say common sense, but they're a little more, they don't take as much thought. I mean, if somebody's deviating from the sagittal plane, so they've got like a shift or something, that's clearly an aberrant sign. If they've got a shake or a judder, is that what that's? Yeah, they've definitely got a problem. Painful, that's an aberrant sign. So these three are a little more, I guess you could say, straightforward. The other two are, have to think about, and you have to know what Gower's sign is. He asked about this in one of the sync sessions. So, but in any case, those aberrant signs, those, if you have at least one of them, then that's something to help rule in this right here, the stabilization. Yeah, that's actually true. Let's see. Yeah, because when you, hip is first and then lumbar. Yes, thank you for that. And this person had a let's see. So a hypermobile SLR. So it did not say they had a positive prone instability test, but then again, you don't need all four. So this person had a hypermobile SLR. I didn't put a number there, but if it's hypermobile, I would just probably assume that it's greater than this 91 degrees. So if they have a hypermobile, when they do a straight leg raise, if it's greater than 91 degrees, that would be hypermobile. That would be another thing to help rule in this classification. And then also, they're 35 years old. So in this case, I think in the last one, it was a red herring. This one actually does help rule it in, because if they're younger than 40, that's another thing. But just remember on this one that the first two are the only ones that are validated. So these first two are really important in ruling them in. The second two, not so much, but they still can be useful. He just said to use 3 and 4 here with caution. And so then you've got stabilization. So hopefully that makes sense. All right, next one. See what this is. All right, which of the following is incorrectly matched for a rotator cuff repair? This is from TI 1. Yeah, I apologize for that, Lauren. I guess that was a lot. I probably should have put a full minute for that. But yeah, so this is the wrong one. Does anyone want to take a guess as to why this one is not right? Is that what it was? Did I actually put? Yeah, it's the grade 5. Yeah, I think this is actually right. Yeah, the time frame should be right. So the main problem with this is that when you start the maturation, so you got inflammatory. That was the first, at least in the rotator cuff repair. This was the first 2 weeks for inflammatory. Then proliferative phase, that's weeks 3 and 4, or I think it's weeks 2 to 4. Which I guess you could say 3 to 4. And then you start the maturation phase. And there was a lot of stuff in the maturation phase. You had one part that was 4 to 6 weeks, and then 6 to 8, and then 8 to 12, and then 12 and beyond. But the thing is here, when you start weeks 4 to 6, you've just gotten out of the proliferative phase. And so the only ones that you would be doing for mobilizations are grades 3 and 4. So grade 5 would be contraindicated for that. And because the grade 5 is a thrust, it's the thrust manipulation, if I remember right. And so you just got out of a rotator cuff surgery. So even though it's in the maturation phase, that could seriously irritate it, damage it, considering that you're not even doing active range of motion at that point. That you've got active assistive. Let's see, where is that? Somewhere. Here we go. So again, inflammatory, you've got the onset of it to 2 to 4 weeks. I mean, we don't have to just drone on about this stuff, but I would probably go back and look at these and just kind of generally know what's done in each phase. Because with this, he had a bunch of slides on this. Yeah, that's true, Jared. Yeah. And he had a bunch of slides on this that took up, at least in that lecture, probably like half of it. So I feel like he wouldn't have put that in there if it wasn't worth a test question. But the main thing that I noticed here with the rotator cuff injury relative to some of the stuff he talked about earlier is that when you're in the inflammatory phase, if you go back and look at, there's a slide toward the beginning of that healing where he talks, where it's a table from some text that talks about, you know, what you do in each phase. It said something to the effect of that you do passive range of motion in the inflammatory phase, like nothing crazy, and just up until the patient tolerates it. But here in the rotator cuff, you've got complete immobilization for 2 weeks. And so I just found that interesting. And it's probably because a surgery like this is a lot more serious, and you have a lot more damage there than you do for most other injuries. So kind of things are a little bit delayed here. One step, I like to think of it that way. So you've got a mobilization in the inflammatory. When you get to proliferative, you begin passive range of motion. In the other slides where he talked about, like, I guess most injuries, in inflammatory, you probably would have started passive, and then in proliferative, you can go from passive maybe to active assistive. But here in the rotator cuff, you have passive in proliferative, and then once you get to remodeling, which is the maturation, then you start active assistive in 4 to 6, active in 6 to 8, and then there's some other stuff like the actual strengthening at 8 to 12, and so on and so forth. So make sure that you note the differences here with the rotator cuff injury than with most other things, because you know, he was talking about, you know, what are the benefits of immobilization versus the cons. And for most things, like if it was just like low back pain or something like that, you wouldn't immobilize. But this is such a serious treatment that you do have to immobilize for 2 weeks. So I would go back and look at that as well, just because I feel like he wouldn't have put, you know, 12 slides in there on that if it wasn't worth a test question. So hopefully I'm right about that. All right. Next one, identify the best strategy. Loss of spinal extension range of motion with pain at extension mid-range. Cool. Yeah, definitely. This is the answer. Hey, by the way, Jared, back to that, I thought I would just explore this just for a second. So with grade 5, what joints would you actually probably do that on if it was indicated? Because I think you mentioned in one of the syncs that you actually worked as was it a tech, or you worked in that facility or something?
Yeah, usually with grade 5s, it's like that high velocity stuff. So,
Right.
you know, your thoracic, your lumbar, cervical manipulations.
Right.
even a little bit in the ankle and the wrist, but the shoulder's just way too movable to really have that
unstable
effect.
joint.
Right.
Cool. Okay, thank you for that. Thank you for that. All right, so this one. So we've got loss of spinal extension range of motion with pain at extension to mid-range. So this is, you probably didn't need it without this, but just in case it comes up. I don't think we're gonna have a lot of stuff, like a lot of responsibility for this per se, but this is with the McKenzie classification system. So remember that here, instead of having functional optimization, movement control, and symptom modulation, here they have postural, and then dysfunction, and then derangement. And then there's different ways to classify those based on the nature of the pain, and also if they've lost range of motion. So postural wasn't really, that didn't seem like anything that was really that crazy. He called it the movie theater syndrome or something like that, where you've sat for too long and you kind of get transiently shortened structures, but it's not permanent. So it's only a positional pain. And then if you move around, the pain goes away. So you have no loss of range of motion there. But here, and this part relates to this question. So the person does have loss of range of motion. It's with extension of the spine. And I think I may have actually in this question, I meant to say pain at the end range. So let's just assume that it said end range. That's my fault. So if they have a pain at the end range of the movement, then that would be a dysfunction. And so in that case, they have some kind of shortened tissue. It's kind of permanently been made like that. And so there's some shortened tissue that's limiting their spinal extension. And so this is one of the cases here where you pretty much go to that repeated movement progression and you do the movement in the direction that's limited. So if, according to the McKenzie system, if you have a limited extension, then that's the movement you would do. And one of the things, and this I wouldn't put it past them to put on there, something relating to, if you remember, one of the benefits of the McKenzie system is that when you're actually doing the movement screens and the tests, you're doing it repetitively. So you're actually getting movement there before you actually even do the treatment. So you're getting the patient actually moving and I wouldn't necessarily call it exercise, but at least they're moving. So that's one of the benefits of it. So this actually has pain at the end range. They don't have pain at the mid range. But in any case, I guess it would be the same answer regardless, because if they had pain at the mid range, then that would possibly imply a derangement. So pain at the mid range really throughout the whole movement, plus a loss of range of motion, then they have a derangement. So that's probably something where they've got maybe a disc rupture, disc herniation. Remember that dysfunction is really just a shortened tissue. So maybe a ligament or something got shortened, or the connective tissue's been condensed or something like that. Whereas derangement, you've got actually damage to the disc, because everything's mechanical here in this system. So there's damage to the disc, and then the disc is possibly compressing a nerve root. And so you might have radicular pain in that case, or maybe even a full-fledged radiculopathy. I don't know if he's going to get much into this. Did he say in any of the lectures whether or not he was going to have much on McKenzie? I know he said that we needed to understand it in case we run into a practitioner who operates this way, but are we really responsible for this in any amount of detail that he had familiar? Is the tree? Yeah, I think from what it sounded like in the slides, it's pretty much the same. And I think the only difference between the two, yeah, so we need to be familiar. Okay. He probably have one or two questions on this. I think that if I understand it right, the major difference between these two is really just the nature of the injury. But you are basically doing the same kind of treatment. You're doing repeated movement progression. So that's what he was talking about, where if you're trying to facilitate extension, you could basically put your hands in front of you and kind of do like oh, what's that yoga move? I can't actually remember what it is, but basically you're forcing yourself into a prone push-up or something like that. You're putting yourself into even more extension, so more and more of that. Centralization with extension is Mackenzie movement. Yeah, and so yeah. Thank you, yeah. And so with derangement in particular, because derangement, you've got the damaged disc, and so the disc might actually be compressing a nerve root or something like that, and so you might have pain in both the low back and the leg, upper leg, and so your goal with those repeated movement progressions is to get that centralization. So you want to move the pain out of the leg and get it back up. Get it back up into the low back region, and so you want to get that centralization, and you're going to do that with a movement that is their directional preference. So basically, in this case, in this question, if extension gave him centralization, then that would be his directional preference, and that's what you would do when you're doing the repeated movement progression. I think really the major difference here, other than that, is just the nature of the actual of the dysfunction. So literal dysfunction is where you have shortened tissue and only pain at the end range, because if it's short and you're stretching it, you're only going to feel that pain once you actually elongate that tissue enough to feel the pain. Versus derangement, you have pain pretty much throughout the duration of the movement. So it's at the end range, the low range, mid-range, throughout. So, okay, let's go on to the next one, see what more we can get done here. Patient presents with marked hemarthrosis, significant bruising, and significant loss of elbow flexion. This is a what, and you don't need to know anything about the structure itself. Let's see. So this one is a sprain. So with these, here it is. Here we are, right here. So this table, these two tables just came directly from. This is TI1. So he said to be one of the objectives in the start of the PowerPoint was we need to be able to differentiate the 3 classifications of sprains and then 3 for strains. So with this one right here, I pretty much just grabbed some of these out of here. So marked hemarthrosis, so you've got blood or bleeding in the joint itself. You've got significant bruising. So marked hemarthrosis, significant bruising. And I don't even know if this is clinically accurate. It's probably not. I just made the point of putting in a ligament there and then a tendon and then grades 2 and 3. So marked hemarthrosis, significant bruising, those are all going to be here. So grade 3 or severe. And then it's a sprain because if we're looking, if we're looking at the choices, so the UCL, that's the ulnar collateral ligament. So that's a ligament. And so you would sprain a ligament versus with the strains, those are going to be muscles and tendons. Bicipital aponeurosis is a tendon. So these characteristics right here match up better with the sprains. And so if it's sprains in grade 3, sprains would have to be the ligament. So that's why here it was this answer right there and not the bicipital aponeurosis. Does anyone want to comment on that or dispute that in any way? I don't know if it's physiologically or clinically accurate. I just made up something that was in that area in terms of the anatomical structure. Does everyone agree or does anyone disagree with that? What do you guys think? Before tomorrow, definitely one of the things you want to do, I think, and I'm kind of doing this with the last chapter in in TI1 is I'm going through the headings at the start of his PowerPoints and just making sure I have a good idea of those things, because I feel like with Dr. Yu, he's so to the point that I feel like if he's going to ask something, he's probably going to favor what's in his lecture objectives. So I'm going through it and looking at those in a lot of detail. So let's go to the next one right here. Which one are we on? Oh, wow, 12. Which of the following is a characteristic of the condition spondylolysis? Yes, so this one, stress fracture of the pars interarticularis. So there's all those spondyle things. So there's two here. One's not, one I didn't find, but it's the spondylosis. I swear he mentioned that somewhere. If he does, the spondylosis is really these two things on the left. So spondylosis is more osteoarthritis in the area, or osteophytic growth in that area between the two vertebrae. It doesn't necessarily have to do with the pars interarticularis. It just sounds similar. So these two would be spondylosis. And then when you're differentiating these two, so spondylolysis and spondylolisthesis, they both involve the pars interarticularis, as you can see in the picture right there. But the difference is that spondylolysis is just either a defect or a stress fracture. So you don't have a complete separation of the two halves of the vertebrae like you see over here. If you have a complete fracture, then you have spondylolisthesis. And so the hallmark of this is that whatever the level is, so in this case, yeah, that's a really good, yeah, that's actually a good way. Longer word, more serious. I like that. I do like that. So you have whatever the superior, yeah, so with spondylosis, again, with normal aging, yeah, so that's not shown here, but with normal aging, you do get things like arthritis. That's more with the inflammation and stuff like that. These two, spondylolysis, defect or stress fracture, and then spondylolisthesis is the complete fracture. And so what I was starting to say there is you've got whatever the superior vertebra is starts to move anteriorly on the vertebra below, or if it's L5, it's moving anteriorly relative to S1 or the sacrum. So that's and they always show this level. It can happen anywhere. I don't think that it's specifically L5, S1. It can happen anywhere in the lumbar spine. It's just that it's really common. Pius says it's common with the female gymnast. Oh, and so you've actually hey Jason, do you mind just was it pretty painful, or how was that? I'm just curious if you don't mind sharing for a minute.
So yeah, my biggest issue actually was the neuro effects. Pain was pretty minimal. Felt it mostly on my hips. But it was when you start running and you go less than an eighth of a mile and you can't feel the pavement, kind of freaks you out.
Yeah. And it's just because of the repetitive movement, the impact up and down. Is that what you think? Is that what it probably was?
I probably had, well, so that's when I noticed, that's when I knew to like immediately right off. That's when I knew something was off.
Yeah.
Prior to that, it was one of those, it was actually an injury that, you know, there was nothing seemed off, but it was when I started running that I noticed that I had issues.
Did it ever hurt if you went into spinal extension? Did you? Because I think they said in the lecture that was supposed to be I think that was a contraindicated movement, was this total like more extension.
So funny thing is actually I felt it more in flexion.
Really?
Yep. But I can tell you that single leg raise is a health indicator. That I saw knew exactly what was going on, sent me for imaging, came back, and there was the good old Scotty dog. He didn't even have to explain it to me.
Yeah. Hey, thanks for sharing that.
Yep.
And Megan, with yours, when you say L5, was it the one that's shown here, L5 moving over S1, the one that's shown there?
Sorry, I'm stuffing my face with pizza, and yes, it was.
No, that's fine. We're having pizza tomorrow, so sounds good after the exam. So, but yeah, so when you have that complete fracture here, it gives the whatever vertebra it is liberty to move anteriorly over the sacrum, and so you don't have that with the spondylolysis because it has not completely separated from it. So, but just remember, I guess based on what Jason said, you can't. There are obviously patient differences, but specifically in the lectures, they did say that extension was contraindicated, and I think it has something to do with the fact that when you go into extension, you're actually going to get that compression of the neural foramen, intervertebral foramen, also called, and so that's going to compress the spinal nerves that are going through that. So, and both of these, you can, as we've mentioned, you can have them elsewhere, but they're just more common at the L5-S1 joint. Stress fracture and extension was awful. Yeah, I had nothing compared to that. Stress fractures are the most annoying fractures you can have. They are. I had one in the fifth metatarsal. Took a year to heal. Probably nothing compared to this, but they're not painful as much as they are annoying, because when you start moving around, I used to play racquetball. It wasn't so much pain that you couldn't move, but it was enough pain to where it changed your movement pattern so that it made it pretty much impossible to play anything competitively. So yeah, stress fractures, they suck. So yeah. Okay, let's go to the next question. So spondylolysis, stress fracture, or defect? All right. This one should be, yeah, two answers. An L5 to S1 right posterolateral disc herniation would most likely interfere with which two actions? Yeah, so it's the first two here. So here you've got, this is kind of more of it's like a two-parter. So you first have to figure out the potential nerve from the cauda equina that's going to be compressed. And this was one of those things that a lot of people are having trouble with at first, is knowing which one, because when you're looking at those nerves as they're, so if anyone wants anything more on this, I actually recorded a video over this kind of explaining it. But the gist of it is like these circles right here, these are supposed to represent really just the entire vertebral canal. Here's the conus medullaris up here. Here's two of the spinal nerves. And so if you're looking at, in the question he had in the PowerPoint, in that question, not this one, but there was a disc herniation at L4, L5, so that particular disc. And if you think about that level, L4 exits through that level. So superficial answer, it might seem more logical that L4 would be herniated. But when you're looking at these nerves as they're going down the vertebral foramen, vertebral canal, which is all of them combined, they're going down and they're getting more and more lateral because they're going to have to exit. And so this L4 nerve, when it gets down to where this intervertebral foramen is, it just exits really quickly, kind of just curves underneath the top part of the foramen. And so it doesn't actually cross where the herniation is. It actually exits before or superior to where the herniation occurs, just slightly. But if you look at L5, it is going to exit below the L5 vertebra in this foramen, L5-S1. And so as it's exiting down here, it's clearly already crossed where the herniation occurs. So the herniation is going to be able to affect the nerve that exits the level below where the actual herniation is. So in this question, this is from his lecture, if the herniation's at the L4, L5 level, that's actually going to affect the nerve that exits at the level below the L5, S1 level, which would be the L5 nerve. So in this one, it's kind of just shifted down one. So here you've got an L5, S1 herniation. That would more affect the S1 nerve. So you're looking then at things that the S1 nerve is involved in. So for example, here, Achilles reflex, that's S1 and S2. So S1's a part of that, so it would affect this. It might not obliterate it completely because it still has S2 input. In any case, it wouldn't obliterate it completely at all, just because it's being compressed. But S1 is a part of that reflex, S1 and S2. And then right plantar flexion, so when you're testing those myotomes, gastrocnemius and soleus, which are the plantar flexors, those were the S1 myotomes. So plantar flexion on the right side would also be affected. These ones wouldn't be because ankle dorsiflexion is L4, and then hallux extension is L5. So that's why these two would not be the answer. So, all right, let's see if we can get through a few more before 6:30. All right, which of the following does not occur during spinal extension? Let's see. Yeah, so it's not laxity in the end. So remember back to some of that anatomy, anterior longitudinal ligament. So on this one, so here's extension right here. So was this one extension? Or, yeah, this is extension. Okay. So so here, if you look at these vertebrae right here, remember that we had something on this in Dr. P's class. I think it was. I don't remember if it was actually, I think it may have actually been the beginning of Anatomy 2. We talked about the cervical spine. I don't think we did it in the lumbar, we did it in the cervical, but it's the same kind of stuff. So when you do extension of the spine, it doesn't matter what section you're in. Extension, you have downsloping or downsliding. I think he termed it downsloping. And then in flexion, which there's another question on that, when you flex forward, you have upsloping. And I think upsloping and downsloping kind of they have a bunch of things that they imply. So in the case of this, when you extend, you're downsloping. So you're kind of, each vertebra, if you look at the vertebra above relative to the one below, so like if we consider L2 and L3, L2 is moving posteriorly and down. So when you go to extension and you downslope at each level, the vertebra above is moving posteriorly and inferiorly. That's the opposite in flexion. When you upslope, it's the opposite. The vertebra above moves anteriorly and superiorly. So here in extension, you've got downsloping, so posterior and inferior. And if you think about what that would do to the intervertebral foramen, if the vertebra is moving down, it's going to decrease the circumference of that intervertebral foramen. So there's going to be less space in that intervertebral foramen. And Dr. Young called them neural foramens, or NF. That's what that means. It's the same thing. So when you downslope, not so much the posterior, but more the inferior part, the movement, it's going to decrease the size of that neural foramen where the spinal nerves exit, which is why generally when you want to open up the neural foramen, you have to go into flexion. Because when you go into flexion and you upslope, the vertebra above moves a little bit superiorly, so that actually increases the circumference of that neural foramen and provides more space for the nerve that's going through and can take compression off of it if it's there. But here, it decreases the size of that neural foramen, and then the facet joints, because it's, you want to explain that, Chris? I don't know if I followed that.
Oh, that was just about the flexion.
Yeah.
People, see people at the grocery store, they always feel better when they're
Oh.
pushing a shopping cart because they're bent over, right? And so that's common. You see that in old people.
Yeah, I forgot.
Older
That's
adults.
actually from week 3, I think, is when we talked about that, right? When we introduced that concept.
It all
So
blurs
this week,
together.
yeah, kind of, yeah. So, so basically, yeah, so if you've got that compression on those, the nerves within the intervertebral foramen, if you flex forward, you're going to actually, because the vertebra kind of move up a little bit superiorly, it's going to increase the circumference of that hole, the intervertebral foramen or neural foramen, and it removes some of that compression off of the spinal nerve. So hopefully that makes sense. Yeah. For stenosis, yeah, that's what it was about with so when they're leaning over the shopping cart, that removes some of the pressure there. So that's the neural foramen. And then you also have the facet joints. And so if you think about the vertebra above moving inferiorly, then you're actually sort of compressing or putting more pressure on the facet joints. So extension, when you downslope, you put more pressure on the facet joints. In flexion, you're moving them, they're moving superiorly, so they're depressurizing or removing pressure, from the facet joints. And then pretty much, then you've got the ALL, anterior longitudinal ligament. And that's why that answer was the one that wasn't correct. So when you go into an extension, remember the ALL is on the anterior part of the bodies. And so if you extend, it's actually being tensed, the ALL. So all the posterior ligaments are in laxity. So that includes interspinous, intertransverse, ligamentum flavum, PLL. Those are all in laxity. But the ALL is being tensed. So that's why this one was false. This is, it'd be tension in the ALL. But the other ones do happen during extension. So you have narrowing of the intervertebral foramina. You have increased pressure on the facet joints during downsloping. And then this is literally what the downsloping is. So the posterior, it doesn't have to be at this level. It can be at any level. I just picked one. But you have posterior translation of L5 relative to S1. So basically just posterior and inferior translation of the top vertebra relative to the bottom one. But I could have picked L3 and L4, L2 and L3. Just it applies for any of them. So that's spinal extension. And the nice thing if you learn those things for spinal extension, then you just flip it for flexion. It's the ligament that yes, that's right. Yeah, thanks, Pius. Yeah, so the ALL, anterior longitudinal ligament, is the main at least in terms of ligaments, it's the main restrictor of the range of motion of extension. And that kind of makes sense because if you think about the range of motion for extension, I don't remember the exact number. It's like 15 to 25 degrees. It's a lot lower range than it is for flexion. We have a much bigger flexion range of motion. And so the major thing that's restricting extension is the ALL in terms of the ligaments. So, all right, next one. I don't know that this is, let's see. I don't remember if this one might be one answer, which is not characteristic of the hemostatic and inflammatory phases of wound healing. Yeah, this one was a harder one because this one has one thing wrong with it, and then it has a bunch of terminology here, which we'll discuss. So for anyone that chose this first one, what was wrong with it? There's one word that's wrong with this one. So when you're in a hemostatic inflammatory, so I think they in one of those, it's technically two different phases. I think a Dr. Yu's class, but we can more or less combine them. So when you're in the inflammatory phase, you can do, depending on the nature of the injury, you can do passive range of motion within pain limits of the patient. just as, as tolerated. You can do those, but stretching is contraindicated in that phase. So stretching of the, I think that's what it was, is you want to preserve the tissue, soft tissue in there, but not stretch it yet. There's a slide that he has. I've kind of alluded to them periodically here. He has one for each of them: inflammatory, proliferative, and maturation or remodeling. And there's like 5 things there of in a lot of detail. But under inflammatory, there's a contraindications thing in big red letters. And one of the things that says it's contraindicated is stretching of that area. You can stretch other areas of the body that are not affected, but you don't stretch the area yet. You can do that in the proliferative phase, but not in the hemostatic, in the inflammatory phase. You can still do the passive range of motion within limits, but the stretching is the one word that makes this one wrong. The other ones are correct. So for example, in the Hageman factor, it was termed that, I think, at least in TI2. I know it was. I don't remember if it was TI1 also, but Hageman factor is clotting factor 12. So that's right, Pius. So if you think about the inflammatory, you haven't gotten the fibroblasts in there that are depositing this tissue yet. So you're still just getting, in the inflammatory phase, all you're doing is you're debriding. It's a chemical debridement. So all these immune cells are coming in, and they're being recruited by different factors, but they're lymphocytes, monocytes, macrophages, and they're just phagocytizing all sorts of stuff, getting rid of foreign invaders, getting rid of nasty stuff. And then once proliferative phase starts, then the fibroblasts start really depositing all sorts of connective tissue components and things. So if you don't have the connective tissue components yet, if you try to stretch it, it's just going to damage it. I think it's kind of like, I had at one point, I had a wound in a really bad place. I had a wound that was right here in that first and second digital space in my hand that I got from, it was just like a chronic, had it rubbed against some weights that had little, what are they called? They have little miniature spikes on the handle. I don't know they're rough, so you can hold them better. And it created a wound there. And this is a really bad place because if you're ever writing with a pencil or anything, if you just move it, you stretch it and it comes open. So that's the way I think about it. So if you're stretching tissue that hasn't yet gotten at least to the proliferative phase, it's just going to become more damaged. And it probably took a good 3 months to heal it. It was really annoying. So yeah, if you stretch it at this point, it would be contraindicated. So that's a point there. Go back and look at those contraindications and precautions there. They're in big red letters, so probably a good bet he'll have some. So Hageman factor is clotting factor 12. Not that that's like super important, but it was named explicitly. And so because you're in hemostatic phase, so you have to stop the blood loss, this is the part of the coagulation cascade that initiates that, factor 12 or Hageman factor. Also in hemostatic, you have vascular spasm. So you just have vasoconstriction, and it was mediated by serotonin and norepinephrine, also called noradrenaline, same thing. But those are chemical mediators that will initiate that vascular spasm. And then also mast cells and basophils. So those are those white blood cells that release histamine. So they release histamine when they're stimulated by pathogens and other things. And that histamine will increase the capillary permeability. And then you can get all sorts of other phagocytes in there to the damaged area so that they can clean everything up. And so these 3 things all happen during the hemostatic or inflammatory phase. I don't know how mean he's going to be. Someone from the last, I don't remember who it was. Someone said, I think the last Kahoot session we had, we were talking about who the hardest class was. And somebody said TI1 or something, was actually pretty hard. And they said that just that sometimes he likes to pull things from the sync sessions. I don't remember if that was in the Kahoot session. I heard that from someone. Someone said they had heard it from a former class, a student. One of the things he said in the sync session, I don't know why this stuck out to me, but during the hemostatic phase, because you have to get platelets activated, he mentioned one chemical that causes platelets to stick. Do you guys remember what? Yeah, it was true. For movement science. Yeah. PowerPoints helped a little bit, but yeah, I should have studied the syncs more there. Does anyone remember what the chemical was that he mentioned that causes platelets to stick? So it wasn't thrombin. It's not really one that we talked about in physio. He said it's ADP. So not ATP, but ADP. Apparently ADP will cause the platelets to become sticky, so they'll adhere to where the wound is, and then they'll help. So they'll help kind of initiate the coagulation with the help of the clotting factors. So anyway, just thought I'd throw that out there. All right, next one. I don't think this one is multi-select. This is not multi-select. What is the most likely fracture type? The left tibia in the case of Anderson Silva's disastrous shin kick. That is not the, okay, I have this one miskeyed. This is not, sorry, that is not spiral. That one's, this is not spiral. So spiral fractures, those are caused by torsional forces. One of the things he said to make sure to look at is kind of knowing the bone fractures. That was in one of his objectives that we need to be able to do. He had some slides on this. I kind of went through here and just for some of them, like mentioned kind of the general forces that would cause the fracture. I don't know if he wants us to know that or just be able to identify it. But some of them, it depends on the nature of the force and also the direction of it. So a transverse force is a fracture that occurs from a force perpendicular to the long axis of the bone. So it would have to come from the lateral side of this bone, either from this side or this side. And so, I mean, it makes sense given that the fracture is kind of cutting the long bone in half perpendicular to its long axis. And so you can have that either from a perpendicular impact. I think that's more common. Or if you imagine parallel tension, so tension pulling it up in this direction and then down in this direction. So pulling it with its long axis. I don't think that's very common. This one would have to be perpendicular tension because in order to get this type of break, you'd have to pull it. If this is the long axis of the bone right here, you'd kind of have to pull it like this in order to get this kind of break. And then pretty much the other main ones would be the spiral fracture would be like a torsion. So if you twist it, Alex Smith was spiral. Was it in the tibia? I imagine it was the tibia, maybe the femur. Yeah. So like what he's talking about is if you had had your foot planted, like let's say your right foot was planted and you had a significant twisting motion, but the foot stayed still, or at least the tibia stayed still, it would basically cause a spiral fracture. So that's the only one here that's a torsion force. And then the others are like oblique impacts, so just impact that's not completely perpendicular. But the whole point is, so that's, I actually, I didn't see this live, but I've watched it on YouTube once. Once is enough. He probably had a pre-existing weakness there because people throw shin kicks all the time. And he threw a shin kick and hit the other guy's shin, but his just broke. Like it just completely broke right through the entire bone. And you can see his tibia is basically like this. So Can't be spiral because it's not a torsion force. Couldn't be linear because the nature of the impact would not produce this type of break. This would probably have to be perpendicular tension. So it's one force pulling this way and then another pulling that way. Broke his femur with a spot. That, I don't, yeah, I don't, yeah, that's awful. Yeah, I don't, I wouldn't want any broken bones. Stress fractures are annoying, but they're not even close to some of these. Yeah, so does he, was it a long time ago, or is it something that he's still recovering from? A few years ago. How long did it take to heal that? So, oh, wow. So he would, nice. So that's impressive. So I'm glad to hear that, definitely. But in any case, yeah, so the nature of the force is pretty much perpendicular. It could be oblique. So it could have been an oblique fracture, but that's not here. So the only answer it could be is transverse. Even though green stick fractures they're still, they can be caused by a perpendicular or oblique force. The way you know it's not a green stick fracture is there's no way that his tibia would have completely bent like this if it were green stick, because the fracture would have had to be completely through the diameter of the bone. If it were green stick, that only goes, you can see it right here, that's just going partially through the diaphysis of the bone. It's not going through the entire thing like the transverse or in this case, the oblique. So in this case, the answer would just be transverse. So I'm sorry, had that one miskeyed. But it could have been oblique also, depending on what the fracture actually looked like under an x-ray. So, all right, next one. I don't know why it says that. This one's one answer. Which of the following does not occur during spinal flexion? Cool, yeah, so this one is the wrong answer. So spinal flexion, so that's where we have, won't spend too much time on this just so we can get through some more in the next 10 minutes. But remember, in flexion, that's where you have the upsloping. So in this case, like L2 and L3, L2 would be moving anteriorly and a little bit superiorly. So that's why this one was wrong. This would be downsloping, what we would see during extension. You're going to get tension in the posterior ligaments there. So posterior ligaments are going to be on tension. ALL is going to be more lax, laxity in the ALL. And then pretty much everything's the opposite. So intervertebral foramen going to be a little bit wider, and then the facet joints are going to have less pressure. Everything's opposite. And then the only other two things here that are different that I didn't have in the previous one like this over extension is that one, remember that flexion increases neurodynamic tension. This is that thing where the entire nervous system from the brainstem all the way down to all the peripheral nerves, it's all connected. And so one way you can increase, so one of those tensioners is you flex pretty much your entire body. So trunk flexion, neck flexion, you can even lift your leg up, so hip flexion, and then dorsiflex the ankle, and you're pretty much just putting tension on the entire nervous system. So spinal flexion is going to increase that neurodynamic tension. Extension would actually decrease it. And then the intradiscal pressure, that was one of those things from the very first week. And he had a question on that in his review for our exam, so I have a feeling it's probably going to be on there in some form or fashion. He had a table where it was just like a bar graph of different intradiscal pressures. So that's just the pressure on the intervertebral disc. And so it was lower in sitting. So like if you were just sitting upright, it would be really low. If you were sitting, but then you leaned forward, it would be a little bit higher. So basically at any position, sitting or standing, the flexion is always going to give you more intradiscal pressure than sitting upright or standing upright. So if you then stand upright, it gets even higher. And then if you stand upright with flexion, it's even higher. And then if you stand upright with flexion and then you hold something with a weight, it gets even higher than that. So what is this? Oh, the graph right here. Thank you. All right, here we go. Yeah, so thanks, Casey. Yeah, so here's the graph if you guys want to see it. I didn't actually have this. But generally speaking, like if you're sitting, it's pretty low. Versus if you lean forward, it tends to get higher. So like here's sitting upright versus sitting leaning forward with inflection. Standing, leaning forward. And then if you start to put weights in, I think the question he had basically was what was the highest pressure. I don't think we have to memorize this by any means, know the exact order, but probably know what the highest one is, I would say, and then probably the lowest. And the lowest would be pretty much laying in complete supine. And also notice that if you go in extension, that takes even more pressure off. So extension, you're gonna have less pressure relative to upright, and then even more in flexion. So flexion, you just get more pressure, which is why when you're lifting something, they say to always lift with your legs instead of bending at the trunk. So if you're doing deadlifts or something like that in really bad form, you're probably putting a huge pressure on the disc. That's why you have to keep your back straight, because if you have the trunk flexion and you can't actually lift that much, you're going to really have problems with the disc there. So he'll probably have one question on that, I imagine, on the exam. So, all right, next one. How many do we have left? I think this is just one. Which of the following is not true of the fracture healing process? Yeah, so this one's the one that's false. We won't spend a whole lot of time here just because I want to get through as many of these as we can. This one's wrong because remember, children heal the fastest. So children, it was actually 4 to 6 weeks. And then adolescents were 6 to 8. And then I think it was like, adults was like 10 to 18. The point is adults, it takes the longest to heal there. Children are actually the fastest, which is why this was wrong. The others are just kind of general factoids. Like the ACL healing, when you have the reconstruction, that guy, he inadvertently found out that if you put cyclical loading on it, because some of the patients didn't want to just stay still, they would move on it, they actually healed better. So actually you don't want to completely immobilize there. Controlled weight bearing is better than immobilization for pain control and range of motion, is generally what they've said. And then this is just the general phases of bone fracture healing. So that stuff can probably just memorization, but the big thing here was that children heal the fastest. And he kind of, if you remember, he was talking about his kids on a skateboard, like his kids, if they ever broke a bone or something, they would heal pretty quick versus he would never want to get on a skateboard. I don't know how you ride a skateboard. I would fall every time I ever used that. So anyway, let's see if we can get through some more of these. Just one answer again. In order to improve shoulder extension, the humerus must be mobilized in what direction? Yeah, so this one's anterior. So on this one, this is again one of those that we did in the last Kahoot. I'll kind of explain what my strategy is for this if anyone wants to listen to this. So he'll probably have something like this on there. Yeah, here's shoulder extension. So I kind of came up with this. So you can use this little thing down here where in the way this question's worded is you're given the movement. Because he can also have somewhere instead of that, he just shows you a picture and he's, you're seeing what direction the mobilization is, and then it's what movement am I trying to improve. This is the case where he gives you the movement and then you have to predict how you would mobilize it. So the way I think about it is you get the specific movement, that's what you're given. From there, you figure out the roll, what the direction of the roll is, and then based on the concave convex rules, you figure out if it's opposite or same, and then you can use that to get the slide, and then the mobilization is always in the same direction as the slide. So the roll is in the same direction as the movement. The slide is in the same direction as the mobilization. So basically the way that works is, so we're trying to improve shoulder extension. So what I would probably do first, other than that, is just figure out when you're doing extension, what direction the humerus is moving. So like when you start here and go in extension, generally speaking, the humerus is going posteriorly. So that tells you the roll is posterior. So really the roll, whatever the mobile bone is, the roll is just the same direction that that mobile bone moves. So if it were, we could say flexion, then the roll would be anterior because the humerus is moving more anteriorly. But if we're doing extension, the humerus is moving more posteriorly. So we can say that. Then you figure out if it's opposite or same. So remember that the humerus is convex, big humeral head, round head, and then the glenoid is concave. And so in this case, since the humerus is mobile, right, you have a convex humerus moving on a concave glenoid. So it's concave moving on convex. And that's the rule you have where it's opposite. So then you can come here and just fill it in. So we know it's extension. The roll is posterior because the humerus moves posterior. Slide has to be anterior because they're opposite. So if roll is posterior, same direction as the movement, slide has to be anterior because we determined it's opposite. And then the mobilization is always in the same direction as the slide. So mobilization would be anterior. That's why this was the answer. So hopefully that makes sense to everybody. I'm gonna go ahead and skip the next one because it's identical. And then I'm just thinking we can do 2 more questions. And then we'll call it from here. And I'll post the link to this Kahoot on, I'll fix that one question, the key, and then I'll post this for everybody. So let's go ahead and skip the next one. Same kind of question. I would be prepared for those on, I'd be prepared for those definitely on the exam. All right, this one, we can do this one too. Which osteokinematic movement is Dr. Yu looking to restore in this picture? Right. Yeah, and Jeremiah made a comment here. It's definitely good. With the flexion and extension, the movement is more of a spin than an actual, roll or a slide. That's true. And I think he also, Dr. Yu said also for internal and external rotation, it's definitely more of a spin too. But what for that little assignment that he put up, I tried this technique for all of them and it works for all of them. So if you can get this, then you can get any question on that. Now for this one, here we go. It's the opposite. So instead of giving you the movement, now we see the mobilization and we have to predict the movement that he's trying to restore. So we just go the opposite direction. So instead of starting with specific movement, now we start with mobilization. And so we look at this, and he's mobilizing posterior to anterior. So in other words, it's anterior. So if the mobilization is anterior, the slide would have to be anterior. And so now the only thing to do is to figure out if it's opposite or same, and then we can predict the roll, and then from the roll we can deduce the movement. So here we've got the hip joint. Okay? It looks like he's moving the femur relative to the pelvis, or the acetabulum. So we've got the femur's head is convex, the acetabulum is concave. So we've got convex, the femur would be more mobile. So the femur, convex, moving on concave. So that's, again, the opposite rule. And from there, we can figure everything out. So mobilization is anterior. So slide is anterior because they're the same direction. And we said it's opposite. Roll and slide are opposite. So if the slide is anterior, roll is posterior. And then if you think about a movement of the hip where you're moving your femur posteriorly, that would be hip extension. And so that's why here the movement that he's trying to restore is hip extension. And again, I went back just so if anyone feels better about this, I tried it for every one of them, that this thing right here, for every one of them that he did in class and on that assignment, and it works for all of them. And the other thing about this that's nice is if you really want to check your answer, once you get an answer for these type, you can do the reverse and backtrack it and see if you get the same movement to start with. So you can do it the other way once you have your answer and check yourself, which is kind of nice. Okay, and we could probably do just one more here, and then I have to call it for the night. So this one, again, just has one answer here. 42-year-old patient presents with adhesive capsulitis and limited glenohumeral range of motion. What mobilizations are indicated? Yeah, so it's these two right here. So again, there's a lot of kind of red herrings in this, like 42-year-old, not necessary. The big thing here is, so you're asking what mobilizations are indicated. And by the way, this was more therapeutic interventions. I don't think we did this in musculoskeletal. So you've got here limited range of motion. So with all of those graded mobilizations, so there's 1, 2, 3, and 4 mainly. 1 and 2 were for pain. So here, nothing's said about pain necessarily, but that there's limited range of motion. And this is probably why there's a limited range of motion. But the point is there's a range of motion that's a problem. So you would use grades 3 and 4. These two over here are grades 1 and 2. So the red one, low amplitude, beginning of range is grade 1. High amplitude, beginning of range is grade 2. And then high amplitude engaging barrier would be 3. And then low amplitude engaging barrier would then be grade 4. So because the issue is range of motion, then you'd use 3 and 4. If it were specifically pain, then it would be just 1 and 2. All right, so that's all I'm going to be able to do tonight. I just want to thank you guys for coming out to this. I hope you learned something here. Hope it made some sense, clear some things up, prepare you for our exams tomorrow. I wish you all the best on the exams. Before you guys go, if you want to, just for a minute, if you guys have any suggestions for that study guide PowerPoint thing that I put together on Facebook, if anybody has any other critiques or anything, I was probably going to post it probably around like 8 or so. We're gonna have dinner, and then I'll fix anything I need to on it, and then repost a final draft for everyone, I suppose. So if anyone has any comments, feel free to come on now and say everything. I'll stay on for a minute or so. Yeah, for this I will try. Yeah, Morgan, I'm going to try to get that done because I still have to look at them. I personally have to. I haven't really done that. So I'll try to get that. What did Chris? Thanks. Yeah. So I appreciate all you guys coming out here for this. It's a lot of fun for me, and I really appreciate. Thank you. I appreciate you guys' input. It makes it a lot better when you guys can provide a lot of experience and just feedback on everything. So I'm going to go ahead and conclude this. If anyone has thinks of anything else for that stuff, just send me a message or something before around 8 o'clock, and I will repost that thing with the few modifications to it. So everybody, good luck tomorrow, and I will see you guys next week. I'm probably going to do, for those of you still on, just mention it, but I'm probably going to do next week clinical neuroscience. We'll do another one of these for that as well. So good luck tomorrow, everybody.